we're going to introduce ourselves. I'm Cindy Cater. I'm a pediatric epileptologist at Cook Children's Hospital in Fort Worth, Texas. Oh, is it not? Oh, I need to talk. Did y'all hear me okay? Okay.
Yeah. Cool. I'm Fabio Nascimento. I'm an adult epileptologist at WashU in St. Louis.
So we're going to be doing a workshop on the LGS care team and care plan. And so when Tracy met with us about this, we wanted to really talk about the evolution of how your care team changes for your loved one with Lennox-Gastaut. And Fabio and I were talking about sometimes your children get diagnosed at age 2, and sometimes they're age 12, and sometimes they're well into their teenage years before they're given the diagnosis. And things evolve and change in pediatrics, and as we've discussed a lot this morning about how different it is when you get into transition and then eventual transfer of care. And a lot of things come up, a lot of scenarios come up, a lot of discussions that we talk about as providers and advocacy groups, and the way that the American Academy of Neurology recommends when we should be starting to have these discussions and how can we be better about it, number one. Number two, what are the expectations? Number three, what are some potential scenarios we'll talk about? Number four, what are your action plans? So we'll talk about this worksheet a little bit. And then lastly, how can we give something back to you that we can make this process maybe just a little bit easier and try to do this as a community across the country. And kind of have a potential idea that we can expand upon for the future. This is very casual, very interactive. We want to hear from you. We want to hear your pearls, what's worked, what hasn't worked, where your challenges are, what you're upset about, what's your ticking point, and how we can best answer that. And like we said earlier this morning, I think Dr. Schell has said, we're not going to have all the answers, and no one expects anybody to have all the answers, but this is how we start working together. The worksheet is basically, it's very long and it's very comprehensive, and it's not in any way, shape, or form where you have to have something written down in every section. It's just to kind of guide you about your loved one's needs and what is it that's happening at this current time frame. And what you all know is that what affected your loved one at age 5 may not be the same thing that you need at age 15, or not the same thing you need at age 25. So while your care changes over time and your providers change over time, you should always be kind of thinking about all of these subspecialties, and do I need them right now, and do I not need them right now? And so that we don't find ourselves, 6 years later, 10 years later, 30 years later, and say, oh my gosh, we never addressed constipation. So just different scenarios, like I said, very casual, very laid back, and we'll get started.
Awesome. So you guys should all have the worksheet. Just going over it really quickly. So there are a few sections here. The first one, you just try to pick the age range where your loved one currently lies at. And then we have 3 different sections. Section A is about who is actually currently on your team, and they have different specialties. You don't necessarily have to fill it all out, but just so we follow together. And then section B, we have who's missing from your team, and you can check off the providers that are not part of your care. And as Dr. Kuetner mentioned, the needs might change depending on where your loved one is at as far as age. And then the C section is the point of contact for the providers that are involved. So that's pretty much it. Any questions so far, comments? Should we get going? All right, yeah. So we're going to start with, so these are the objectives that we just laid out to you guys. I'll skip this part real quick. So let's start with the transition, which I believe is one of the most challenging stages for us. A lot of you guys might be already aware of the principles that the Child Neurology Federation put together with the AAN. So we're just going to go over it together just to make sure we're speaking the same language. And that's going to be important when we talk about the scenarios and our experience from the pediatric side, from the adult side, and most importantly, y'all's experience in y'all's journey. So there are 8 principles. So again, we're just going to review it together. So first is about the expectation of transition. So the child neurology team with caregivers should lay out this expectation of transition, and that should be initiated as early as, or as no later than the patient's 13th birthday. as a goal, right? As the ideal scenario. Number two, the yearly self-management assessment. So the pediatric neurology team make sure that there is one in place beginning at age 12 and then annually thereafter. And all that should be documented in the patient's charts. So that's number two. Number three, annual discussion of medical condition, age-appropriate concerns. So again, the pediatric neurology team should engage with the patient, caregivers, family in this transitioned planning, patient education, and transfer readiness at least once a year, beginning at age 12 as well. So all of them starting pretty early. And most of the principles are guided and rely on the pediatric neurologist or the pediatric provider. Number four, evaluation of legal competency. So the child neurology team should initiate a discussion by age 14 years with caregivers about the expected legal competency, document it, assess it, and start a conversation about how to go about it once the transition age comes about. Number five is annual review of transition plan of care. So by age 14, the pediatric neurology team should assure that there is a transition plan in place that meets all the needs of the patients and families and caregivers. So that's important as well. Number six, the pediatric neurology team should develop and verify the neurologic component of transition plan and update it annually. If you guys have any questions or comments, please just stop me at any time. And then this is more where it kind of overlaps with the adult epilepsy care. So number seven is about identification of an adult provider. So the pediatric neurology team should, in collaboration with the patient and caregivers and families, find an adult provider that is appropriate, familiar with the condition, and willing to take on the patient's care at the time of transfer. That should all be done before the time of transfer, obviously. And then the pediatric neurology team should try to help coordinate that transfer as well. And eighth and last, when the transfer is complete, the pediatric neurology team should communicate with the adult provider about the patient, the issues, the challenges, what's been done, what's not been done, to kind of close the gap and then take the step of actually moving the patient and family and caregivers to the adult side ultimately and officially. So that's kind of what's out there. One note, this is not focused on epilepsy exclusively. This is a neurology transition guidelines. Granted, it does apply to epilepsy as a chronic neurological condition, but just so you guys are aware, these are guidelines for any chronic neurologic condition. So it's not exclusively for epilepsy. All right, any questions so far? Should we move to scenarios? Okay.
And real quick, I want to clarify, in my mind, and I think this is something I've learned, is there's a difference between transition and there's a difference between transfer. And so I think when you look at some of these guidelines that Child Neurology and American Academy of Neurology have given us some outlines and some expectations of what to look for, there's a lot of talk about this at 12, talk about this at 14. And the reason behind that is because transition takes a lot of time. And even when the children turn 18, it still takes a lot of time. And sometimes we're 21, we're 22, we're 25, and that's okay. So I think that, remember that transition is the process. It doesn't mean we're moving on and this is our last visit. It's just these are discussions where let's start thinking about what that looks like, so that everybody's prepared for when that transfer does happen. So transfer is really, okay, we've found the provider, we've wrapped everything up, we've done what we needed to do, we've identified all the ins and outs, and now we're moving forward, versus transition could take multiple years.
Can you repeat what's the body that put out the guidelines?
Yeah, for sure. Let me go back to the paper here. It's right there. So it's the Child Neurology Federation together with the AAN that came together and put together the guidelines.
Because 12 sounds really early. But the reason that age 12 was kind of the number is because it takes so much time, and so much is going to change between 12 and 18 or 12 and 21. And, living in the United States, insurance companies and all that's going to change as well too. So there's a lot to think about. So I think that's why starting to think about it at age 12 sounds very early, but from our perspective, I think we forget to talk about it, and we really should talk about it more often.
And to be realistic, we've done some research on this. These goals are rarely met in real life. So for the most part, it takes a lot longer to start the discussion, to update the plan. So I think we should see this as the ideal scenario, but in real life, probably it doesn't work exactly like that. Yeah, I'm sure you guys know this much better than we do. Thank you for the question. Anything else? Yes?
So do these guidelines still hold so in my sister's case, her diagnosis wasn't until she was 17, and she started with a pediatric neurologist, and she's now 20. I don't think this is on, but that's okay.
Is the third mic on?
She's 20 now,
Thanks.
and she's in the process of transitioning. But as far as I'm aware, and I'm her sister, so I don't know quite as much as my mom, but as far as I'm aware, the pediatric neurologist didn't really do much to support transition and just told my mom, hey, you need to find an adult neurologist. And I think between 17 and 20, she's been through 4 different neurologists at this point. She also has Rett syndrome, and most of them had never heard of Rett syndrome before. And so I guess my question is just, do these principles still apply even though she wasn't diagnosed until she was 17? She did start with a pediatric, but they didn't really help a whole lot with the process of transitioning now that she's 20, almost 21.
I can start, and then I'll let Dr. Keaton weigh in. I think it's more complicated when the diagnosis comes exactly at the time of transition, right? So definitely that makes it a little bit more challenging. But even if it didn't, I feel like in our experience, it's very common that it's really hard to find an adult provider that is familiar, willing, has an insurance status that is compatible with the patient. So unfortunately, I think it happens quite often. What happened to you guys? Dr. Kieran?
And these are guidelines, right? These are no way mandatory. These are no way this is what we expect everybody to do in the medical community. These are guidelines that are encouraged in how we can do things better. But again, there are always exceptions, right? You know, you get diagnosed at 17, 18, or your diagnosis changes. We'll have a scenario where you were told you had one diagnosis, and then right before you became an adult, your diagnosis changed to LGS. Now what do you do? And so again, these are real things that happen. And so, you know, some of our case scenarios are from our own patients. And so it's very helpful to speak on those pearls. And do we have other questions? Otherwise, we were going to have a parent.
I'm a mic runner here, so if anybody had put up your hand, and I'll run a mic to you.
Just a very naive question. Is there a list of, does the LGS Foundation has a list of kind of like adult providers specialized in LGS, especially talking about neurologists, not just epileptologists?
I believe, yes. They have always on their website,
I
correct?
guess, yeah, I can answer that. So we have a Find Your Doctor and Find Your Comprehensive Care Center page on our website. The doctor ones is really short for adult providers, but it's not because that's all there is. It's because, pardon me, we actually like to take recommendations from the community. So if somebody wants to self-refer and we've never met them before, we might want to know a little bit more, because we want to be able to confidently say that there are people that really, think, yes, this is an adult provider. But that doesn't really happen. We don't really get people saying, hey, put me on your list that often. What we want is our community to be reaching out to us as often as possible and saying, I don't see my doctor's name on there. Could you add him or her? Because that would really help us too. And adult providers, I get a lot of questions from families saying, hey, do you have somebody, wherever I live, kind of thing. So I'm going to stand over here so I can see everybody when they raise their hands.
Hey everybody, I'm Trisha Profrock. I live here in Florida. I've been one of the ambassadors on and off for the LGS Foundation. That's my sweet guy Mason over there taking a nap by the door. And we are currently in the transition period. He turned 18 in December. So looking around, it kind of looks like most of us are probably transition age or older. Maybe a couple are not there yet. But I also agree with what Jen was just saying. When I have been an ambassador, one of the main questions that everybody asks inside the group is, what adult care providers, who can we turn to? So I'll just share a little bit about Mason's story to catch you up on where we are in his care plan. So he was diagnosed with LGS when he was 3. And so yes, we always joke that we collect specialists over the years, and we have, dropped away from a few. There was a time when he had to see a cardiologist, and thankfully that's not an issue anymore. So, but then recently we've onboarded GI and dietitian, and he had to have a G-tube placed just before his birthday. So a surgeon, he's going next week to the surgeon. She's going to help me replace his tube, and then in 2 weeks, he's going to see he's switching neurologists for the first time because he's 18. So the thing that I want to add to this is, in the pediatric world, at least for us, he's been followed by Nicholas Children's Hospital. So a good chunk of his specialists, they're all in the same network, and there's some cohesiveness when you're followed by a children's hospital. I honestly don't know if that transfers into the adult world, where you're with one hospital, one group, and I didn't think so. But that has been so nice, because we see, they're all part of this network with one hospital, and so they can look up things. When he's an inpatient they can look at all the records. Every specialist that comes in when they're doing rounds in the morning can look at everything, and that's so helpful and so nice. And so that's a very scary thing, thinking that very helpful piece of the puzzle isn't going to be there. So being part of that network, they let me know at his last neurology checkup that he was going to be transferred to somebody who sees the patients once they've turned 18, still part of the Nicholas Children's, because they see up to I know one of the doctors told me they have like a 26-year-old patient that they still see in Nicholas Children's Hospital, but I know that's not the norm. So he sees his first, we're saying goodbye to his neurologist that he's had all this time, and switching for the first time in a couple of weeks. So we have to be in person for that. Does anybody else love the telehealth visits? Way better. But this is going to be an in-person to meet his brand new neurologist. The gap in my knowledge is I don't know how long we're going to have this one. Like, is this going to be until he's 22? Is this going to be for the rest of his life? Like, we don't know those things because they don't tell us. We didn't get a lot of the steps done. We heard about it, and so I feel like we were prepared going in. Like the day he turned 18, we made sure with the legal guardianship and everything, and he's on the waiver wait list, and so we try to be proactive and think ahead. And I think a lot of us are like that, because the only way to keep your ship sailing and not sinking is to keep your hands on the wheel. This transition is hard to know where you're going. You're like sailing into a foggy cloud. And you do rely on others who have been there before you, or it's just like, it's a mystery, and it's hard to not have a complete direction, but things like this help. So I thank you so much for helping and giving us an opportunity to ask questions and to learn from each other and to learn from you. So.
And I think another goal that when Fabio and I met with Tracy about this, another goal of this workshop is how that care changes. So in pediatrics, where all of us came from, right? All of our loved ones started in pediatric care, as LGS is a pediatric diagnosis. Your pediatric neurologist or your epileptologist in that care team does pretty much probably 80%, if not more, of what you need, right? They do your referrals, they sometimes do your medical supplies, your diaper supplies, sometimes your suctioning, your feeding tubes. They help coordinate your care with your other specialists. They're helping call the GI doctor, the cardiologist, the sleep doctor, and coordinating that stuff for you. But as you get older, that changes. So for those of you who have moved on to the adult world, that's very different. And so I think another thing that we want to talk about this workshop is, where do you fit in that care team, and how do you help navigate that? It's very different in the pediatric world. And then as an adolescent, that's why, Fabio had mentioned, where is your loved one? Are they in the pediatric? Are they teen? Are you getting ready to transition? Or are they in adult care? Because once you get into the adult care, your primary care provider is likely going to be the one that's going to do a lot of your supplies, while your neurologist or your adult epileptologist may really only do the epilepsy care at that point, because it's a little bit switched, and they do things a little bit differently in that scenario. And so it's kind of helping us as well, us learn, but also helping kind of have a discussion about making sure we always kind of keep in our forefront, where do I fit in, and how can I be that advocate, and what's my action plan for when my loved one gets to that age group, and finding not only the adult provider for epilepsy, but also the adult provider for the other things, and the primary care provider. Because I guarantee you, for those of you who have children still in the pediatric world, all of my LGS families come to me when they need school forms. They don't go to their pediatrician. They come to me. Why? Because I see them every 4 to 6 months, and I fill all their supplies. And obviously every state's different in the United States, but the way our state is you have to see, depending on your insurance, if you've got government insurance or Medicaid, I have to do all the forms because I see them every 6 months, and that's the way the state is. And that's fine. I'm happy to do it. I become their primary care provider, more so than their pediatrician, who just does their annual checkup and their vaccines. So again, it's kind of to help that process of that workshop of how we can be better, and what's the action plan as that process happens.
I have a quick question about the transition, the guidelines that you were talking about. Is there a guideline for what needs to happen at those first appointments? Because if you haven't, my son did not have the benefit of a warm handoff. In fact, his medical records, I don't think have ever made it over to his adult epileptologist. So it really was me with all of the information in my head. And I'd love it if somebody could I'm just wanting to plant a seed, to have like a checklist, like what do they need to do what would a good scenario look like? Would it be they're ordering some certain labs, and maybe they're ordering an EEG, and when to do, when certain things need to be covered by the new provider, and because the previous provider is going to hand them, let's say, a perfect record, and they're going to have a great conversation and a wonderful, they're going to be really well informed about everything when that patient becomes part of their team. But what would we love to see happen in that first year, maybe, or leading up to that first year, and then that first year?
Yeah, good, and thanks for sharing, Tricia, your story. To your question, the short answer is there's nothing like that. There's no checklist for the adult provider, and that's good and that's bad at the same time. I think it's bad if you get somebody who's not as familiar with LGS, and there's a little bit of a familiarity gap there. But it's good because if you do get somebody who is a little bit more familiar, they probably don't want a checklist to go off of, right? They want to make decisions on a patient-by-patient basis. They want to communicate and connect and so forth. I'm not defending either approach. I'm just, neutrally speaking, I think it could be good and it could be bad at the same time. But there isn't something like that out there. Yeah, but Dr. Keeter has, right?
Yeah, I like your idea though.
Yeah.
I love it. Yeah. But I have something at the end, kind of what we're doing in Fort Worth, and what I hope we start doing collectively as a community.
Awesome. Yeah, please.
There is already a standard of practice in a sense, because when you get a new patient should have a standardized, these are the 5 things they need to know, but you want the fresh mind, what he's saying, because you want someone out of the box. If you give them already the playbook from your first neurologist, it will alter his fresh ideas. So you want, this is what I have for you, your job. We are paying you to solve this mystery.
Right.
So it's
Yeah.
good enough.
Yeah, exactly.
There is standardized intake.
Right,
Yeah.
yeah,
Yeah.
for every patient coming into the
Agreed,
clinic,
yeah.
that's right.
And I've
that's
heard
for sure.
that before when one of my patients has transferred and they've come back and they've said, this wasn't a good fit, we need to find somebody else. And they said, they saw your notes and they're like, well, what do you want me to do?
Yeah.
And I'm like, that's unfortunate, we'll do better, and so we hear that a lot. They'll say, everything's already been done, I'm not gonna change anything.
But there should be
Yeah.
kind of a standardized, something across the.
Like in a perfect world, we're talking about in a perfect world, and the experience of our families, it doesn't always match that, right? Yeah.
And then we get that trauma from our journeys that we can't remember. Ask me
Yeah.
my daughter's first MRI, first 5 years of life.
Should have brought you a mic, I'm sorry.
Yeah. No, that's
Yeah,
exactly. That's why we're doing this. Yeah. And maybe let's start that with the first
Yeah,
case
yeah.
scenario.
we're gonna go out of order, so just
yeah.
bear with us.
Yeah, but I'll start with you because I think it's really important. We hear this all the time on the adult side. In fact, the session prior to this, there was a comment from a parent that was in the line of, I get to my adult provider, they ask me what medications my kid is on, and I say, look at the chart. It's a lot, and it should be in there, right? And just to give you a little bit of opinion from our side, and I'll pause there to say, my disclaimer is, nothing I talk about is related to my employer, and I'm going to try to be a neutral provider. I'm sure there's very good places out there and very bad places out there. So I'm giving you guys the average adult provider experience and opinion, okay? So let's say you come into the clinic, your kid is 23, and they had a 17-year-old chart who came to the adult provider or not. Sometimes it just doesn't. Sometimes it's in the same system, and then we can see it. Now, you have 17, 18 years of data for a provider to look at when there's no time that we can bill for to look at charts. The clinic is full, and we have a new patient just before you guys and a patient just after, right? So we have a limited time slot that is a little bit larger at academic institutions, shorter in the private practice world for the most part. And there's just no time to go over everything. And personal opinion, that's why we don't have adult providers on the website. For somebody to want to do a good job, you have to give your time that's non-reimbursed and a lot more than your regular adult epilepsy patient would take. And that's the difficulty. So that goes more for you guys to understand, our side, the neutral adult provider. So if you come and the adult provider asks, what medications has your kid tried? And I've heard that multiple times in my clinic, the moms get upset. And I understand that. They're like, well, just look at the chart. You have all you need in a full stack of papers or on your computer. But it's not as easy. If we don't get something very summarized from the pediatric provider, which we rarely do, it's just there's not enough time, effort, ancillary support, nurses, MAs to help the physician to review everything for us to know everything that's going on at the first visit.
We should develop a paper.
Right,
That we
right.
have all our medical records. And
Correct.
just hit the key things on the front.
Right.
Was that you that said your first 20 pages were the important stuff in another talk?
Oh, I think that was maybe
And I'll
Jamie.
show
Was
you
it
one
Jamie?
too at the
It was
end.
maybe, yeah.
Yeah.
Oh, no, Tiffany, I think.
Similar to that, I was thinking, what's the least amount of information, but the most effective information you would request from us parents
Right.
to come to that initial appointment? What's the best that we can give you that's going to help you recognize 17 years?
Right. So Dr. Keeter has developed a very nice worksheet, checklist that she's going to go over in a little bit. There's an answer to that. It's actually not as much as you would think. And Dr. Keeter will go over it.
Yeah.
If we could get that from the parents, and I'm a big advocate for that, it's going to be so much better than relying on a pediatric provider that may or may not give us the records that we need. And if they do, they just print out a million pages and just send it to our office. You know,
Well, and
it's
then those million
unrealistic.
pages have like a bunch of nursing notes and your vitals and your labs. And I'm like, no, I need the meat. Like, you know, so when I get second opinions, I get the same thing. It's no different. I'm like, I need the meat. I need what happened in the last 6 months, what happened the last visit, every med they've been on, exactly, EEG, MRI, yeah. Yeah, I've done it long enough where I can fill in the gaps with the mom. Yeah, yeah, yeah. So we'll talk about that.
Yeah.
Are
If
y'all okay
anybody
we go
has
to-
any comments, by the way, say them into the mic because we need them. We're recording all
Okay.
of this.
Got it.
So
Sorry.
just for future use, put your hand up if you're going to say something. I've got a question back. Hang on. There's one ahead of you right back here. Thank you.
It's not necessarily a question, but what's been going on my phone, I have the notes. And in my notes, I have medications that he's on, emergency that he's on, any kind of surgeries that he's had, the dates, anything that he's gone to that hospital, he's gone to this hospital. So if I were to go anywhere, I have everything on my phone that if a doctor were to ask, so that he doesn't have to look through that. But it has taken me time to do this. But once it's there, if he had his RNS put in, I put the date he had his RNS. He had a VNS battery change. When did we do the VNS battery change?
Right.
So everything is so
Yeah.
easy to put on your
Yeah.
phone. It just takes time to do
Yeah.
that.
So two comments there. One, not every parent is like you, right? In fact, the majority are not like you for many reasons, right? That we're not here to judge, but it's hard to keep track of something like that. There's a lot going on in people's lives, and especially when it's a complex case. And number two, there are some information that we need that unfortunately you wouldn't be able to put on your phone, you know, when it comes to like EEG findings or MRI findings or genetic testing. These things are as important, but it's hard to summarize on a, you know, succinctly like that, concisely on your phone like that. But having that helps so much. Yeah.
Microphone.
Yeah.
I'm sorry, if you had
Yeah.
the date that it was done and the hospital that it was done at, then it can be looked back upon.
With the caveat that sometimes it's not the same system. Sometimes we have no idea where that was done. It was another state, right? Or sometimes the provider did not send us anything. Or, you know, there's a lot of obstacles to that, but I totally agree with you. That's wonderful and super helpful if we have that to go off of.
I think we have one at the front here.
Yeah, I just wanted to take a second to plug the Care Compass tool. I realize like caregiving requires a lot of note-taking, obviously outside of the medical setting. So there's a lot outside of medical notes and medical history that need to be recorded. And I think Care Compass is a great place to do that.
Are y'all good if we go to some scenarios and we'll open up the table to more discussion? Okay.
Should we start with Pete or any order? What
Do y'all
you think?
care where we start or just kind of go all over?
All over?
Okay.
Okay.
We have 9. We probably won't get to all 9, but we'll definitely get to the 2 pediatric ones.
All right. And Dr. Keaton and I will discuss our adult and pediatric opinions as we go through, but mostly we want to hear from you
And,
guys.
and Tricia will too, when, you know.
And Tricia will as well, yeah.
Absolutely.
So first case, 25-year-old male with LGS comes into the adult epilepsy clinic. Like we were saying, the pediatric chart is not available. Mom has some notes on her phone, but other than that, we're blind to everything that happened for 23
Plus
years. Yeah. So then what do we do? Yeah, put yourself in the position of the physician, right? For a second.
And again, the idea of the workshop is where you fit in as their care provider. Like how are you navigating that? Not only you, but where does your doctor fit in also as the focal point of the care provider, as part of the team? And I think we've already talked a lot about this already. You know, I loved what you said, you know, put it on your phone, you know, especially with the way technology is with our cell phones and apps where you can plug things in. Makes it a little bit hard with, you know, with medical information, but, you know, there's the law that passed that allows families to have immediate access to their health information. So because of that, it should be a little easier to be able to get that information as a parent, to do that on your phone. So I think that was a great idea of what you can do.
So, when my other daughter, not the one with LGS, had to go to the orthodontist, like I got mailed this huge packet where I had to give all this past health history. So I just think if you have an appointment, like why can't it be like those other health sectors, right? Where you give us what you need before we come, because your time's so valuable. We're not going to see you again for for months, right? So that's kind of how I think about it.
Yeah, there's a pediatric discharge package that's published on that has all the relevant information that should be transmitted to the adult provider. That is officially supposed to be filled out by the pediatric provider, but that oftentimes does not happen. So if we did have that, it will make it a lot easier. And then we can speculate as to why it doesn't happen. On average, of course, there's centers that do have them and some that don't. And one, just talking to pediatric providers, Dr. Keeter will weigh in as well. The pediatric providers are just as busy as we are, if not more. And they also don't get bill time to fill out another form to be sent out to the adult provider. And number 3 is summarizing 20 plus years of information. So that takes a lot of effort and time from the provider as well. So those are speculative reasons as to why it doesn't happen all the time.
Yeah, and again, this is, like we said, we're going to tie it up at the end, but that's where this worksheet comes in. That's where I love your idea comes in. And also my worksheet that I'm going to explain to you what I do in my clinic back home of something we can do and give back to the parents, so that when you do go, if they don't get anything, you're like, great, here you go. And that's the other idea, is that this is, like I said, like we want to come away with an action plan. Like, look at the different specialists outside of your neurologist that you need, and start thinking about, oh, my child, has this issue with their development, or this issue with their wheelchair, and their equipment, or this issue with their feeding issues, and so again, just kind of helps you kind of put those things into that action plan for when this process happens.
We have a question back here, and then you're next. Okay.
So I was going to mention one of the things Jen and I were talking about was the Learn from Every Patient database and owning your own data, because for me too, that's made it super helpful. Even if I'm looking back at like, what meds was he on back then? Because I remember like he did better when he was on that. Like, what year was that? Because the doctors aren't going to remember, even though he's seen the same doctor forever. And so that's something that I'm thinking as part of the transition, at least, having all of the medical information in one place. And I think we have some tables in the exhibit hall about it as well. And that can also help with just having everything together in a way that then we can summarize it to bring it to the adult physician. Anything else?
No, I think that's great. And then phase 2 of that is the surveys, but really phase 1, it's so easy to sign up, and I've done it. And Lisa was also mentioning it to me, so, before you even said it. Oh, what? Oh, sorry.
I've also used the AI feature in the Learn from Every Patient database and asked a question and had to look through all of his records to find something. So that was super helpful.
Awesome.
Okay,
Next.
my question, I guess my thing would be, why couldn't we, before the appointment, similar to what she was saying, is get a release of information things where we can say, okay, we're going on this date, here's the release of information, so you guys have that when we get there.
Yeah, you can, and it's the patient's right to get medical records. The problem is, number one, sometimes it takes time.
Yeah, it
and you
doesn't
have to-
happen as always
Yeah.
smoothly, and it's center dependent.
Right.
Like, yeah.
And when it does happen, as Dr. Keeter mentioned, then a lot of other useless stuff comes with it, and then it's hard to parse it out and see what's actually important. But just to not be as pessimistic, I think we always talk about 2 solutions, right? Just to wrap up this case, I guess. One solution is, unfortunately, give you all more work, which is not fair. But until we have a better solution on the medical side, to have you guys try to keep the records in one place that you can show it to the physician if the adult provider doesn't have it, right? It's not ideal, but that's one solution. And the second solution is what Dr. Keeter will present. From our side, what can we do to have a checklist and make sure we have all the information that actually gets transmitted to the adult provider at the time of transfer?
And also show, like the parent was saying, I don't know everyone's names, I'm sorry, about, hey, this medication did work. So it can, something that can track those things for you. Because as we all know, our children have been on so many medicines and retried them too, right? A lot of us have been on, hey, we're trying this for the second time and see maybe it works this time or better. So, jogging our memories because we, I know all of you guys go through a lot. We have a question in the back. Do you want to go to the?
We have one back here.
Yeah, well, one more question, then we'll go to the next scenario. And then Tricia, do you have anything you want to add? Okay.
I'm learning so much already.
Yeah. Well, hold on.
Is it my turn? Yes. Okay. I just had a comment that I wanted to make, and it kind of goes along with the conversation we've been having. So, and by the way, my name is Mallory Alonzo. I'm with an industry partner, UCB, but my comment has nothing to do with UCB. So, there is a digital care platform that was developed. UCB was involved in it. Oh, you mentioned it. Oh, I'm sorry. I didn't hear you.
Yeah, I'm responsible for it. So I'm listening to all your ideas because I want to implement them in the app for you. So come and talk to me about all your ideas, please.
All right.
Okay.
Keep going then?
Yeah.
Okay, cool. So second case, 30-year-old female with LGS coming into adult epilepsy clinic as well. There are some behavioral issues that are untreated, and there's a referral to adult psychiatry. And there are problems related to that in the adult side, probably a little bit more than in the pediatric side, in the sense of there's not a lot of psychiatrists out there that are taking new patients, as I'm sure you guys know. And the ones that do are usually out of pocket, or they have very limited insurance compatibility, which makes it very challenging. So in the setting of patients with behavioral issues and psychiatric comorbidities, it's really hard for us to be able to have a psychiatrist to help manage those conditions. Dr. Keeter, any comments?
I mean, I think we have the same problems in pediatrics more than you think. For adults, I think it's the same thing. I think we have it actually might even be harder from a pediatric standpoint. It's in pediatrics, I think the big issue is that when you have developmental delay or autism, a lot of psychiatrists won't want to be involved if there's behavioral issues on top of it. So a lot of us in the pediatric world refer to developmental pediatrics, which are probably twice as hard to get into as a psychiatrist because there's less of them. In the state I live in Texas, and even when I trained in Colorado, it was the same issue. Psychiatry is like pure bread and butter, like no other medical comorbidities, versus a child who's got Lennox-Gastaut with behavioral issues usually gets referred out to developmental pediatrics. So I think that's where that issue, I think it's where it comes up, where we need to kind of define having both providers if possible.
Any questions or comments for you guys? All right. You have one? Yeah.
I think that one of the hardest things is to determine if your person is acting up or if there's a reason that this is happening. That's hard.
Yeah, it's a great question. I think maybe what we're getting to is all the behavioral issues need to be ruled out not to being seizures or after seizure event, right, or medication side effects and whatnot. I feel like that part is easier because the adult epileptologist / neurologist should be able to tease that out with tests and just conversating. But then getting to psychiatry to help, if they are actually psychiatric, then it's a big bottleneck for us. But it's a great point, yeah. Any other questions? Cool. Case 3, so 35-year-old LGS coming into the adult epilepsy clinic. There's some sleep issues reported by the parents. As I was just talking about, we're trying to rule out seizures as the reason for the sleep problems. So there's a referral put into the epilepsy monitoring unit to rule out seizures as the etiology, as the cause for sleep problems. And then a problem comes, which is the familiarity of adult EMU patients with providers with intellectual disability and behavioral issues. So just to sum that up, and for you guys that have adult kids or adult loved ones, not kids anymore, when you guys come into the adult epilepsy monitoring unit, it's very different from going to Dr. Keeter's epilepsy monitoring unit, right? The adult techs and nurses and MAs, they're not as familiar with managing our patients with intellectual disability and behavioral issues. And I've experienced that myself, and it's very frustrating because that doesn't depend on the physician solely, it depends on the structure, right? And then there's only so much we can do to impact the structure to receive these patients. So that's the first problem. Dr. Keeter, any comment?
Yeah, I mean, I think in these scenarios, like you were saying, as they get older, I mean, I see this already in my teenage patients, an 8-year-old patient with just intractable epilepsy is not the same thing as a 15-year-old, patient with intractable epilepsy if you've got behavioral issues on top of it. So, I think that this also applies to that other group, which is your adolescent phase as well. Makes it really hard to do any of these studies, right? So, the comment keeps coming up of how often should we do EEGs? Well, EEGs are important when you're trying to answer, is it behavior, is it seizure related? It's an excellent way to answer that question. But when there's behavior involved, you may not be able to get it. And it's not exactly benign while an EEG is benign procedure, it's not benign to sedate a person to get an EEG, and it also alters the result. So once they finally wake up, they're just gonna rip it off. And so, I find myself a lot as a care provider doing a lot of things based on clinical judgment. And I think that's the hard part of our careers is, we do have great technology, but we can't always use it in this population. And, having those relationships with our families, whether we're a pediatric or an adult provider, and just using your clinical judgment and how we can best serve the population and say, you know what, I know your sleep is bad. I don't think there's any way we could do an overnight sleep study where you have to have oxygen on, sensors on your heart, your lungs, your head, and essentially be still in a bed. Like, come on. Like, that's hard for anybody. And imagine a teenager or an adult with LGS. That's just probably not going to happen. And so I think a lot of times you're just really having to make that decision as a provider, whether you are the neurologist or you're a sleep expert. And so really having those conversations with your adult sleep colleagues and saying, hey, I know this is going on and really would appreciate any advice you would have on, some sort of treatment option, whether that's some sort of CPAP or BiPAP, again, keeping that on, or do we want a medication to help with sleep? So I think a lot of it is just really your clinical judgment and just having that relationship with your family. You had.
I'm trouble.
You're not trouble. I love all you have to say.
Yeah, my name's Corey. I'm from Arizona. I was a CVICU nurse, and now I'm MICU, SICU. I stayed away from neuro because my daughter is actually neuro ICU, and I get that at home. So my question is, it's absolutely true. If I go to the children's hospital and I tell them A, B, and C is wrong, I think she's going septic, they will listen to me. We will automatically go back. I went to the adult first, and I said, ABC is wrong. And they said, no, we just think it's a little infection, and blew me off and sent us home. And I just went immediately to Phoenix Children's, and she absolutely was going septic. Actually, she had, we think, post-anesthesia rifidamide syndrome, but we can talk about that later if you want. It's something with rifidamide and anesthesia, and it's rare, but it's a thing. What about, for these children, the point-of-care EEG, like a Cerebell?
Mm-hmm. Yeah.
Do you guys do you have, because the EEG is standard,
right,
and we all love that, but for the intellectual disabilities and the behavioral issues, the band that goes around their head for 2 hours, do you feel secure enough in those readings that it could, or is it just not good enough?
I'll let Dr. Nasi meant to answer first, but then I have my thoughts on that too, but I'll let you go first since I did the last talking.
No, yeah. No worries. It's a great question. So I guess first answer is all the studies that looked at point of care EEG, and cerebral is one of them, did not include a lot of the LGS and DEE patients that what we see. So that's one as far as validation and verification. Second is the background activity. So like what's going on at all times in patients with LGS is busy and busier than normal. If you throw in a cerebral, which is a limited or rapid EEG, it's a limited montage, you get less data. It's hard to know if it's just regular background information or status, So it's a lot more complicated. I would personally not trust it for the patient population that we're talking about. That's my opinion,
Yeah. I agree with him. I don't trust it, which is why we don't do it. However, I think we're at the very beginning of what we can do with it. So while right now we don't trust it, ask me in 5 years. We might be using it on everybody because technology is moving so fast and AI algorithms are running so fast where they can do validation and prediction models where this is your DEE population and you can start showing it and compare it to normals, start comparing it. This is what a normal EEG looks like. This is what a slow spike and wave background looks like. This is what generalized paroxysmal fast activity looks like. This is what tonic seizure looks like. And now these are other patients with epilepsy that don't have LGS and what they look like. It's going to take time, but given where we are now from where I was 15 years ago when I was an epilepsy fellow, I wouldn't have dreamed that we would be doing the things we're doing right now with epilepsy surgery and LGS. So just think about it even in 5 years because we're moving that much faster. I think we're going to get there. We're not there yet, but I think that's a great topic. And I think that, maybe in the next couple family conferences down the road in the next 4 or 5 years, we'll be talking about, that technology and how we can use it.
And the other point that you raised, I think, is relevant for all of us. Conceptually speaking, the adult side is a lot more used to caring for autonomous patients, right? Versus the pediatric side is used to getting the family involved, right? Making decisions together and whatnot. So I think the DE, LGS patient population, when they come see the adult side, we, as in adult providers, we have to change what we do, our operation, to tailor that particular family or families, It's not to say it's not our gut reaction to unfortunately, to listen to parents, as much as they do, and get them involved in decision making. It's just a different model of care that works for the majority of adult patients because most of them are legal competent, right? They don't have intellectual issues to the extent that they can make decisions. But for our particular LGS DE population, it's a completely different ballgame for what we're used to, and that it makes it, and it spills into the ancillary support just as much, right? Right. Right. Exactly. Right. Yeah, I think it goes back to training. We need to train our new physicians differently, to be more aware and mindful that some patients and families require a different model of care than the others. And it's doable. And I don't know if I'm being overly optimistic, but I feel like our fellows are doing a lot better job in the adult side than the old schooler adult providers, It's a lot closer to us. And then training our staff, which we try to do in my experience, to know that there are other problems that need to be addressed when a patient with intellectual disability comes into the epilepsy monitoring unit, right? You have other things you need to look for. You have to listen to the parents a lot more than you would for a regular adult epilepsy patient, But we're not there yet, unfortunately.
And more LGS patients are living with this diagnosis as an adult, and we're seeing more of that. And I think as we see more of that, because technology is advanced for the better, as a pediatric specialist, I spend more time talking with my adult colleagues as a discussion with this. So I think we're talking about it too. So it's just like, like we keep saying, we're going to get there. It's just going to take time, and it's going to take education on everybody, not just families, but on the physician side, on the nursing side, on everybody.
We have an adult neurologist right here, so we're making way.
Yeah.
Well, we had one at our previous talk in this room, and And there was a doctor that was actually, there were two doctors, and one was expressing his frustration about how, what are we doing as far as educating the adult not educating, but, bringing them up to 2026. And we discussed, what about what happens at AES, right? Because that's where you get the biggest convergence of
Yeah.
epileptologists, neurologists, everybody from around the world, right? Can there not be some sort of somebody create a great talk on what we think adult epileptologists need to know? Because I don't know if my talk earlier, I said, admittedly, adult epileptologists admit that we need to be doing better.
Right.
But the fact that you're here, you are doing better. It's the ones that aren't here, that aren't maybe watching all of these recordings from this conference and engaging with the LGS Foundation and all the other DEE groups.
I have strong opinions about that. What I would say is shortly, we don't need more lectures. We need young physicians to come to clinic with us and see you guys. That's what we need, right? To expose to the patients, to see them, to examine them, to listen to them, listen to you guys. That's the only way for us to get the new generation of adult providers to do a better job. Lectures, we can go to YouTube these days, right? And then we're really good at answering questions on a multiple choice exam about LGS, right? That's pretty easy. But having this exposure, I think it's the way to go. And it's harder to get, right? But it's the future, in my opinion, yeah.
Do you ever see maybe, how there's in the adult world, there's the cardiologist, but then there's all the subspecialties of everything. I mean, because some adult neurologists will basically just say, I don't want to take care of these complex kids. And they shouldn't have to, I don't think, if you don't want to do it. Would you ever see maybe it be in a subspecialty of, okay, we're all adult neurologists, but over here we will see those intractable, devastating diagnoses of LGS, Dravet, all those, and kind of split it so at least you're going to someone that wants to take care of you, that wants to learn about that will maybe have some extra training on that?
Yeah. Great idea. Realistically speaking, I think the number of patients with DEE is so small compared to the whole adult epilepsy world. It's hard to have somebody just special. They would just go bankrupt, You can't justify your job to seeing just DEEs. That's one problem.
Maybe they just, so I know you go to a cardiologist, my dad goes to the cardiologist, but then his cardiologist also happens to be one that specializes in his AFib. So he wouldn't see this cardiologist in the same group because he doesn't do that. So that's kind of more my thought. They would still see regular patients too, but they would just maybe have the extra training of how to deal with the DEEs.
Yeah. That 100%, which is essentially what I do. My practice is focused on DEEs, but I do see a lot of regular, if you will, adult epilepsy patients. And that's growing, and I think it goes back to training the new generation. Because if they see it, they like it, they're interested, and then they incorporate that into their own practice. The one problem is private practice. Because of the reimbursement model that we have, it's really hard to do both. Because let's say you have a new LGS patient at 1 p.m., and you have 20 minutes to see them. And then you have another 15 patients after that, and 10 before. And then, it's really difficult. And I see that. I'm not a private practitioner, but it's a big problem, It's a little bit unrealistic in the midst of our current policies and reimbursement models. Yeah, that's my opinion.
I think this is a perfect place to just give a little gentle reminder. We're talking so much about the responsibilities of the new providers and everything. I just want to remind us all of the responsibilities of us as the caregivers also, because I put myself, these are perfect for me putting myself in the shoes of the specialists, and I think it must be so challenging because you're getting these adults, you're getting their parents, and we have been fighting for our children's lives for 18 years. And I think that we come in a lot of times with a mindset, we're primed for a fight almost. We've heard the horror stories, we're afraid, we're nervous, and we need the provider to know, I've got this, I need you, but we've done this. And so a lot of times I think we can get really rigid and not be open to a relationship it's about forming a relationship with a new provider. And if you come in guns blazing, right off the bat, I feel like it's just really important to remember that we have a responsibility. Just like we want them to listen to us, we need to listen to them too, so.
Appreciate that. In interest of time, we're gonna have jump forward in a couple more cases, and then we'll get to the wrap up of the talk or the workshop. I'll have you skip that one. Go to, yeah, this one, yeah. I'll do this one really fast, because this one's near and dear to my heart, because it's my patient. Yeah, he's not 15 anymore, but he was 15 when this happened. And so he had generalized epilepsy, like flat out generalized epilepsy. Had Apsons, GTCs, had regular generalized 3 Hertz spike wave, polyspike wave. It was a no-brainer, and did really, really well for years. And then all of a sudden, Mom came to my office and said, he's doing this weird thing where he kind of falls. And I was like, what? And he obviously he has trisomy 21. He has a complex congenital heart too, so he's got some pretty significant delays on top of that. So he's a little bit more delayed than your typical trisomy 21 patient. And so I wasn't sure, I was like, is it behavioral? Is he acting out? He's trying to get attention. Anyway, so we brought him in, and lo and behold, that's what he had on his EEG. So he had an EEG that was very consistent with Lennox-Gastaut. So something happened. That trigger happened. Why did it happen at 15? I have no idea. And so, the International League Against Epilepsy redefined the definition to include patients under the age of 18 and younger, because we are seeing these other ones pop off in their teenage years with a diagnosis of LGS. And I know we had a sibling who was mentioning that for their loved one at age 17. So had slow spike wave, paroxysmal fast activity, which we talked about this morning, had tonic seizures, and at the time, their neurologists, this is kind of back in time, but they weren't an epilepsy doctor. This part I'm actually adding as a scenario. So the first part's true. They were already my patient when this happened. But what if, the current neurologist was not an epileptologist? And, just like in adult world where may not be used to DEEs, there are lots of general pediatric neurologists in the community that are not used to the diagnosis of LGS, and they don't like giving the diagnosis, and there's a lot of people that go in this world that are never given that diagnosis, and they have it. And so how does that parent now who's got this information because of technology and can Google it and say, wait, I know better, there's something I can do more. So what are the steps in getting that next step? And so, again, like an action item like to talk about is, where do I fit in? Is, take it upon yourself. Create that list of what you need to do. Ask your neurologist, hey, can you do this? Because if you can't, what are your recommendations of where I can do this? Where's my closest facility that can do comprehensive epilepsy care or an epilepsy monitoring unit stay and answer this question? Or, hey, do I have LGS? I've had a lot of families ask me that before. Is this LGS? Or is this Dravet syndrome? Or is this whatever? They ask me that. And those are legitimate questions. And sometimes it's not epilepsy at all, and that's great. And so where are your advocacy groups? Like, who do you go to? Like here today, like the LGS Foundation. Who do you go to? And so these are things that I think about for my families, that when they ask me, like, where do I go for support? So I give them advice, the Epilepsy Foundation of Texas, if they have specific syndromes, specific epilepsy support groups, and then talk about their quality of life, because school's going to change now, and their therapies are going to change. And then kind of think in your mind, what are your expected outcomes from doing these interventions? So anyway, it's just my kind of case scenario of where do we find ourselves when our diagnosis change? Where do we find ourselves when we're trying to make a diagnosis? And any questions or things that have popped up in y'all's journey about that? Any thoughts? Okay.
We have one
Okay.
Kind of going along with that, when my son, who's about to turn 27, was diagnosed with LGS, there was no foundation. We Googled it. There's nothing there. And so, for us that have kids that are older, there was nothing around. And then I never even looked back for a couple, like maybe 10 more years. And then I was like, oh, there is a foundation now. Didn't know that. But there is so much if you get a diagnosis of something, look it up and see there is a support group out there now for you.
And Facebook groups and.
Yeah, yeah. I mean, LGS has so much stuff, so, yeah.
Find your family.
Yeah, definitely. Anybody? Yes.
Yeah, another question. More than a question is a comment. So for us, the caregivers, maybe sometimes it's difficult to understand the process of what a transition of care program is. So I just wanted to ask you to give us kind of like a big picture of the big challenges associated with the implementation of a transition of care program. So parents, can understand that it's not as simple as we may think it is. So there is money, there is time, there is billing, there is insurance, right? So especially in one of my areas, is like there are two different institutions trying to establish a transition of care program. That's even way more challenging than doing it in a big institution that has a pediatric and an adult providers, right? So if you could tell us a little bit about those challenges so we can get a better understanding, so we can understand you better and not judge you so much.
Yeah. Do you want to do because we have on time, the worksheet or the work. Your slide. Yeah. This is my solution to it, and it's just the beginning of it. And I wish it was more perfect. But building your roadmap. And this morning there was a lot of conversation about this. So when you talk about transition, because there's different phases, and I think that's where that first little section comes up, the different age groups. And where are you? Where are you in that phase? Are you in the pediatric phase and you don't have to think about it? That's fine. Are you getting older and you have to think about those things? And so build your roadmap. And then I think one of the things that we can do better as physicians for our families is collecting the information the same way. Because the way I do something is probably very different. Like Dr. Perry said this morning, he might pick clobazam, but I might pick fenfluramine. And so why is that? And that's okay. You can pick different meds, but at least collect the data of why you did what you did and in the order you did it and what's been tried and what hasn't been tried. And not just for the epilepsy. When did this start? Like you mentioned, what was the date of your RNS? When was the date of your VNS? Were you on keto diet? Did it work? Did it not work? What ratio were you on? Did you ever see a sleep doctor and why? And so answer all those kind of questions so that it kind of helps guide you. But you collect it all together the same way. And so the questions are very kind of binary in the sense that you can only answer it one way. And you don't have a lot of free texting except for maybe some genetic stuff. And that way, if we all collect it the same way from center to center, then we can all look at it the same way and we can start looking at trends and patterns of how we can do things better. That's the first step. The second step is it gives you a tool of everything that's ever been done. And then wouldn't it be great if your electronic medical record could just copy it forward so you're not entering it every single visit? So not every visit's an hour long. Your next visit is so much faster because you just click the button and it moves everything forward and you go through and has anything changed? And then you can add anything that's new, like new medicines, new surgeries, new specialists, or are your seizures? And then you can also look at outcomes. Hey, is your child doing better or not doing better? And why is that? So that's kind of the gist of that. And then as things change, again, I keep coming back to this, is as the pediatric expert, I feel like I do a lot of the comprehensive care for all the things, and which I'm happy to do, but that's not always true of my adult colleagues. And there's reasons for that. And so, I think the pediatrician is where it starts, and you kind of help the provider do these things, and you guide them through this plan so that when you do get to the adult world, you don't feel as jumbled and as lost. And so then the adult provider has everything they need, and like you said, we have a care team, so you're doing it kind of cohesively so that when you do have to find those other specialists, it's hopefully a little bit easier for that transition. I'll go to the next slide. So what do you need? Not comprehensive, but this is just what I think you need. And we're going to touch on this real fast. So like I said, epilepsy characteristics. What are the main features of Lennox-Gastaut? And when did you see slow spike wave? When did you see paroxysmal fast activity? When did you see tonic seizures? Who is on your team? What consults do you need? And we'll list them all for you, so you don't have to think about them. We'll list all those specialists, and you just pick the ones you need. What has changed? What's your CGI score? For those of you that don't know what that means, it's a clinical global impression. So we use a lot of this in clinical trials where a patient comes in who's on a clinical trial. So they may be randomized to drug or they may be randomized to placebo. We're blinded, nobody knows. And you ask, is your child better, worse, or the same? And then you ask those questions and you can mark that. So I like to do that every time I see my patients with LGS because I like to say, hey, since we put you on XYZ drug, or since we did the VNS, is your child the same, better, or worse? And you can track those things. And then I'm not going to go through each one, but you kind of get the gist of all the things that I think about from a neuro standpoint. This is just the neurology part. We haven't even got to the other stuff. And I think it's really important to talk about, has your loved one had status epilepticus? Have they, do you talk about your rescue plan? Because again, you can't, I do have that GI pulmonary. I recently had to add gynecology because I'd forgotten about my menstruating females. That's really important. And we have to deal with that. And who wants to, are we going to make it stop or are we going to let it happen? And those are discussions we need to have. And so every time I see a patient, I'm not going to remember all this, but I have a form that's going to remind me to do these things. And then next slide. Okay, so what does the template look like? So this is from my electronic medical record. So the idea is I'm still fine-tuning this. So when it is ready to go and really where I love it, I want to share it with the EPIC dictionary. So for those of your centers that do have EPIC, my plan is to share this. It's a flow sheet that you can add to your clinic template. And so you can any of your centers can just grab it and share it. And so this is what I'm talking about in our we have something called the Pediatric Epilepsy Research Consortium. So in my Lennox-Gastaut group, my goal is to share this with everybody so that we can all collect it the same way to give back to the families so that when we always have it just throughout your care in pediatrics, but also when you move on to the next step, you have it all. Not gonna lie, I might have stolen the idea from my complex cardiac doctor, who's an adult doctor, but he does this with his complex congenital heart patients who are now in their 30s and 40s that, were at our institution when they were little kids. But this kind of gives you an idea, like you see the time points, this is 2025 in September, the things that the family told me, and nothing changed, but I can copy it forward the next time I saw them. In May of 2026. So it's like, I don't have to enter it every time. You just, boom, copy it forward. And we'll go to the next slide. And so we talk about their surgery. And so you can see, like in the surgery section, in September, we had done some things. And then if there's a little text box, that means that there's something I wrote in there. We try not to do that, but sometimes you have to. And then you can see in 2026, he'd had a surgery, and then I added, well, how are they doing? So angle classification is how we, as doctors, score their surgery response and surgery or epilepsy improvement. So a score of 1 means they've had greater than 90% seizure reduction. So for this patient, it was very successful for their tonic seizures. We can add all their images. Now, it doesn't have raw data, but it can at least put in the information. And then next slide. So this is where we put in seizure meds. And we can, at every visit, we can say, what are you on and what have you failed? And every single visit, we can update that. Genetics, has there been new testing? We can put that all in so you have that. And then a couple more. This is kind of there's some, again, I added GYN and some other things, so this is the old form. But you can see, you can open all of these, so the physical medicine and rehabilitation, you open it up and you can say, hey, have you seen physical therapy? Have you had a referral to the rehab doctor? Do you have equipment needs? So again, your neurologist is sometimes going to be very focused on just the seizures, but we need to focus on everything. And then what we like is that it can create a note for you. So while I put this all into a flow sheet, what good does that do me? I have a little phrase I can put into the EMR, and I put blah, 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 and then it just takes all the stuff I put in that chart on the flow sheet, and it spits it out into a note. And so that's what that looks like. So anyway, so that's what I can use, and that's what I would give my families is, here's a copy of this, and it has everything that has ever happened to you in the care that you've had with me. And I think if we could do that, that's at least a step. It's not going to fix everything by no means, but I think it's a step where how we can help that transition plan and what needs, in my opinion, like how we can at least start moving forward.
Any comments, questions?
Are you going to share that this December at AES?
Not yet. My plan is I am going to share some stuff at AES. I have a poster on, there's a case scenario that we haven't gone through. I'm going to share our data on looking at gross motor function score. So I have a passion with this data set. One of the things I did is I worked with, we have a best practice measure at our institution looking at patients with mobility issues and hip dysplasia. And so in patients with LGS are obviously very, very high risk. So we were missing a big portion of our patients with spasticity, of whom many have LGS. And so I have a poster on looking at my data and how well we're good at scoring that and getting them to orthopedics. So we're showing some snippets of this, but not the actual flow sheet. We're getting there. Probably not this year, but I'm hoping if we don't share it at AAS, it'll be something that'll be shared with the pediatric epilepsy community, so all institutions will have it. And so for those of you that don't know, this is like my build for an LGS center. So I see not only my patients with LGS, but I see all my partners' patients with LGS at least once every 12 to 18 months, and just go through that flow sheet so that all the families have that. So when they do transition out, it's not, I have protected time for that, so I'm going to be honest, like I have extra time to do that. So I have the ability to see all those patients. So that way they have all that when they transition out. So that's the idea, is that can we be better about building this in every pediatric epilepsy center so that we can give something back to the families and to the community. And, selfishly, I want to track things in natural history and be able to show things so that we can start collecting patterns on patients with LGS so we can understand what is that high-risk group. We all know that there's so many thousands of reasons why children develop LGS. And so can we keep going back to like, how did that fire start? And that's what Tracy talks about, like how did that fire start? So I think by doing this, yes, it's great for care and for parents, but also from the clinician standpoint, it allows us hopefully to start looking at patterns of identifying those groups before they develop it, and can we actually do something impactful before that fire starts? So there is a research initiative behind this. This is the start, and then we'll start taking it apart, collecting EEGs and stuff like that. So stay tuned.
Awesome.
Yeah.
Just last comment to your question. We wrote about our experience coming up with the transition program. Happy to share the article if you haven't read it yet. So just to answer briefly, I think there's two big problems. One, assuming you find an adult provider that's familiar and willing to take on patients, the problem then goes to billing. A lot of the time is not billed for. And number two, infrastructure. So when the pediatric side, on average, has a nurse that's dedicated to the epilepsy clinic on a 1-to-2, 1-to-4 ratio for 4 physicians for 1 nurse type of thing. They have an MA, they have somebody, the coordinator, to help get test schedule and schedule them into clinic. In the adult side, for the most part, there's none of that. There's very few nurses that serve a lot of physicians. There's no nurses dedicated to the clinic, let alone to the transition clinic. So it's really, it's a one-man or one woman or one-man show as far as the physician taking it on and trying to do the best that he or she can, That's in short. Yeah. So it goes back to policy change, right? Until we're able to make some changes in reimbursement and infrastructure, in other words, money, right? If there's
like I
more
said,
money.
to be transparent, I have a grant that allows me to do this, to see all these patients.
right? Money put into the adult transition program to pay for the nurse, to pay for the MA, to give the physician time to see patients with DEEs, to go to the pediatric appointment that's not billed for, but at least reimbursement needs to come from somewhere. It's going to be really tough. And our list on the website is going to be really short until then, unfortunately. I think that's and I like to be very realistic with you guys, right? Because a lot of the times I feel like it's hard to just give out the problems, but it's the only way forward. So that's why.
But I will tell you, since I've been doing this for a little over a year, like I have colleagues across the country that ask me, how are you doing this? I want to do something similar. And it's going to take time. But while I have some extra money and time to do it, I can get it started and then share it. Like the idea is to not hold it together and it's only mine. Mine's just to give it away. And that's why I'm doing it.
Yeah, and I think what gives me hope is that, I'm hearing these conversations and I'm hearing, well, we just can't do it because we don't have the time or we don't have the resources or, whatever it is, right? And that's great because then we're saying, oh, okay, so that's what we need to do, as opposed to, oh, okay, and then just walk away because now we've been given a really lousy reason for why things are realistic, but boy, that sucks, that kind of reason for why things are happening. Then we have to know that as a community, there's something, as Tricia had said, we have to think as a community, what can we do then to be part of the moving of the needle, I guess. Yeah.
And just know that, there are, we do apply for funding, like we love what we do. Tracy always laughs at me because there was one time we were on a call and I said, well, LGS is fun. She goes, no one's ever called it fun. And I said, well, and the reason I say that is, the hard part about, I think for me, and this is just a little bit about me, is that I love what I do. I've always wanted to be a doctor since I was 5 years old. I didn't know what kind of doctor I wanted to be, but I always knew I wanted to work with children in chronic care. And it's hard, all of my patients are my families, right? It's really hard. And some I get to still see and some I don't for other reasons. And, we've all been through that. And day in and day out, it takes a toll on you. And when I say LGS is fun, is that this project, gave that spark back to do it. And, there are physicians that really care, that look for those opportunities to get the funding and the resources and the time to do these things for the other hundreds of thousands of people who need it. Yeah.
Sure, go ahead, yeah. I'm so sorry to talk so much.
No, I love that you talk.
No, if anyone else, you want me to shut up, you just wait outside, and then when I'm done, you can come back in. No. Yeah.
You're from Phoenix, I'll remember.
Yeah, I am. I'm from Phoenix, yeah. And, but that was a great point that she made about not coming into the doctor's office with your trauma and your anger. You're a team. And sometimes you feel that power struggle and you have to say, actually, what is our common goal? It's to help this child. What can I do and what can we come up with to help? That is a good point. My other thing is I wanted to say that this problem with the transition is, I don't want to say is fairly new, but is kind of new. And really so all these issues that we have in this culture, in this system, is because it's kind of newish in a sense, because the pediatric growth and innovation and brilliance is our children are surviving. Their life expectancy is no longer 1 to 2 years. We are seeing 55-year-olds, 65-year-olds. This age, this bar is raising, and it's because this is what the flex should be, really. Pediatric neurology and epileptologists have done such a great job with our children that they're handing it off to you, but your system is not ready for it. They did not expect for all these children to survive. So if we could change the culture and be like, the real flex is how long can we help these children live? Is one idea, because it's a hard job. And so I think it's fairly new. So these issues with the billing and the actually having to research these complex cases you guys weren't prepared for this. And it's hitting you at a higher number. We already know this epidemic with autism. It's coming. These children, we know about therapies, we know about everything. We have Amazon. I just bought a whole bunch of rehab stuff before I came here because that's what I'm going to do with my daughter, So I think this is just the beginning, that we'll keep getting better. You know, there's so many of us here with our kids in their 20s. And when I was starting out, you know, or I would even say 15 years ago, we kept being the oldest person. And I'm like, oh, and I'd see a 20-year-old or a 50-year-old, and I'd be like, oh my gosh, there's hope. I'm in rooms, Facebook groups full of older ones. So I just wanted to say, I think it's a new issue, and I think the parent side where we can push on here is backing LGS Foundation and being very loud, and not loud as aggressive, loud with ideas, loud with, let's make a LGS National Day, enthusiastic and positive and motivated. One thing LGS could do that my daughter has schizencephaly. So what we did in that group is they came up with a paper to make a National Schizencephaly Day. We should do that with LGS.
Yes.
And then make it so all of our states, we can all, some of us that have the time, can go and ask for that day and push and get the name out and all that stuff. Sorry, that's just.
LGS Day, November 1st.
Oh, we already have one.
Yeah. We are wrapping up. And that the next session is back in the main place, but I don't know if you had some closing comments that you wanted to make.
No, we just had a closing summary that just reviewed stuff, but we're good.
Okay.
Yeah, so
Loved
it's
it.
just the action item. So you know, the whole idea of the worksheet and what Tracy wanted to get out of the workshop is identify your action item. Obviously, there's multiple that we've talked about. What's missing? What are the gaps? And be familiar with what your physician's done. And ask those questions and ask for a better way to do their care comprehensively, and have that up to date at each visit.
Yeah, awesome. So just my close remarks. I think on the side of a parent, I would highly recommend, number one, don't be okay with an adult provider that doesn't know what they're doing. Just find somebody else, right? Get a second, third, 20th opinion. There are good ones out there, and it might be hard to find them sometimes, but just keep trying. At the same time, come in, as Tricia said, with an open mind, and be careful with expectations, right? It's not fair to compare our resources and our infrastructure with theirs. There's a lot more money in the pediatric side of things, and resources is just a fact, right? And then, yeah, those are the big ones I think for and then third and last, keep track of information for your loved one. Don't rely on the medical system at this point to have it for you. So keep your note on your phone and try to keep the reports and so forth ready to show to the next provider.
That's fantastic. And let the LGS Foundation know, if you look on our website to see if your provider's name is in that list, and we'll add them if they're not there. So thank you, and thank you so much for this.
Thank you, guys.